Hello everyone. In this video, we are going to discuss about immune hemolytic anemias, and also we'll discuss about hemolytic anemias due to uh, trauma to the RBCs. Okay, let's start with the immune hemolytic anemia. But before going into the diseases, first of all, we need to understand about the Coombs test. So, what is Coombs test? Coombs test is basically designed to identify anti-RBC antibodies. That means those antibodies which can bind to RBCs. Okay, and this Coombs test is divided into two types. One is the direct Coombs test, another one is the indirect Coombs test. The basic concept is in direct Coombs test, we are identifying those antibodies which are already bound to the RBCs. Okay, as you can see here, this is the RBC and this is a antibody which is bound to the RBCs. And if you want to identify these antibodies, that is the direct Coombs test. But in indirect Coombs test, we are identifying antibodies present in the serum. Okay, we are identifying anti-RBC antibodies, those which are present in the serum but not yet bound to the RBCs. Okay, so this concept is clear. So in direct Coombs test, we identify anti-RBC antibodies bound to the RBCs. In indirect Coombs test, we are identifying anti-RBC antibodies in the serum. Okay, so they have different indications. In certain situations, we do DCT, and in certain situations, we do ICT, that is indirect Coombs test. Those things we'll discuss subsequently in individual sections. Okay, let us start with the direct Coombs test. So what happens? So as you can see here, this is a RBC which is already bound to antibody, or sometimes it may be bound to some of the complement protein, especially the C3b, especially the C3b. And this antibody can be IgG, it can be IgM, it can be IgA, it can be any antibody. Now, after taking these RBCs, we will add the Coombs reagent. So what is Coombs reagent? So Coombs reagent is, it is anti-human globulin. Anti-human globulin. That means it is also antibody. It is also antibody which is against these human antibodies. Okay, human antibodies, otherwise known as the globulins, human globulins. So we are providing antibodies through this Coombs reagent. We are providing certain antibodies which are directed against these antibodies, these anti-RBC antibodies which are already bound to the RBCs. Now what happens? Now what happens? If these RBCs have already bound, if the antibodies have already bound to the RBCs, there will be agglutination when you add the Coombs reagent or the anti-human globulin. How is this happening? As you can see here, these are all RBCs which are having these antibodies, which are having this anti-RBC antibodies. Okay, now we are giving anti-human globulins. Now these anti-human globulins are directed against these antibodies. So now these anti-human globulins or the Coombs reagent can come and it can bind to these antibodies. It can bind to these antibodies, and this is a process by which it can actually bring in a lot of RBCs which are bound to antibodies together, and this process is known as agglutination. This process is known as agglutination. So after adding the Coombs reagent or the anti-human globulin to the RBCs, if there is agglutination, that means these RBCs are already bound to the antibodies. These are already bound to the antibodies. So that is why they are producing the agglutination, and this is known as, and if they're producing agglutination, we call it as DCT positive. That means direct Coombs test positive. Okay, so I hope it is clear. So this is the pathogenic antibody, anti-RBC antibody. We are providing anti-human globulins which are directed against these antibodies. And now this anti-human globulin, this is the Coombs reagent or anti-human globulin. Now this anti-human globulin is identifying these anti-RBC antibodies, and they are bringing in all the RBCs together, all the affected RBCs together, and they are producing this agglutination. And if you are finding agglutination, that is interpreted as DCT positive. DCT positive. So this is the concept of direct Coombs test. It is otherwise known as the direct. It is otherwise called as the DAT. That is direct anti-globulin test. Direct anti-globulin test, because we are adding anti-human globulins. Okay. So this is about the DCT. So if you understand DCT, ICT is very easy. ICT is otherwise known as the IAT, indirect anti-globulin test. So here we are trying to identify the antibodies which are present in the serum. So as you can see here, these antibodies are present in the serum. These are anti-RBC antibodies. they are not yet bound to the RBCs. So in the so we'll provide them test RBCs. So in the lab, we'll provide them test RBCs. First, we'll provide them test RBCs so that these anti-RBC antibodies can bind to this. They can bind to these RBCs. Once they're bound, we'll add Coombs reagent. Coombs reagents are nothing but anti-human globulins. These are actually polyclonal anti-human globulins. This concept we'll discuss later. What is polyclonal antibodies and what are monoclonal antibodies? For the timing, you remember anti-human globulins, they will contain polyclonal antibodies. Okay, and the rest of the things are similar to what we have discussed for DCT. So if this RBC, if the test RBCs are bound to the anti-RBC antibodies which are present in the serum, there will be agglutination because of this anti-human globulins or the Coombs reagents. And if this is positive, we will tell it as ICT positivity or IAT positivity. Okay. So in a nutshell, in direct Coombs test, we are going to identify antibodies which are already bound to the RBCs. In indirect Coombs test, we are identifying anti-RBC antibodies which are present in the serum. Okay. So indication for both are different. Indirect Coombs test we usually do the pre-transfusion testing, or also we do for RH isoimmunization cases. And direct Coombs test, we generally do this test for autoimmune hemolytic anemias, as we will discuss the warm type of warm autoimmune hemolytic anemia, cold hemolytic anemia, and also we'll discuss about the drug-induced hemolytic anemia. In those conditions, we do this direct Coombs test. Okay. Now, when you read those topics individually, then you will be able to understand why this particular test is being done in that condition. Okay. So this is the basic concept. This will now start with the immune-mediated hemolytic anemia. So first, we'll start with the warm antibody type hemolytic anemia. Okay. So first of all, why it is called warm? Because in this condition, antibodies they bind to RBC at 37 degrees centigrade. Okay. So this is important. So antibodies can bind to RBCs at 37 degrees centigrade. That means it is the normal core body temperature. And usually IgG antibodies are the culprit, and sometimes IgA antibodies. Okay. IgM antibodies, they do not bind to the RBCs at 37 degrees centigrade. Okay, that's why IgM antibodies are responsible for cold type hemolytic anemia, and IgG antibodies are responsible for warm type hemolytic anemia. Okay, there is one exception that we'll discuss later, but just remember that IgG antibodies, they are responsible for warm type autoimmune hemolytic anemia. Okay, so IgG antibodies are important. Very rarely, sometimes it can be IgA also. It can be IgA also. One more point I forgot to tell. In direct Coombs test, apart from antibodies, you can also identify the complement proteins, especially the C3b. This is also important. Okay, in direct Coombs test, you can identify the antibodies which are bound to RBCs, and also you can identify some of the complement proteins like C3b, which is attached to the RBC surface. Okay. Now come to me. So what happens if we have anti-RBC antibodies against our the antigens over the surface of RBCs? Now these antibodies can actually bind to the RBC. As you can see, this is the RBC, and we have one antigen over the RBC. The antigen can be anything. Okay, and now this IgG, which is recognizing this antigen over the surface of the RBCs. Now this antibody can actually bind. It can bind to the RBC. Once this antibody bound to RBCs, this IgG can be recognized by the macrophages. It can be recognized by the macrophages, especially the splenic macrophages, because macrophages have a receptor that is known as FC receptor. Okay, as you all know, these antibodies have a FAB fragment and FC fragment. So this portion which is binding to the antibodies, this is known as the FAB fragment, and the other portion which can actually bind to the complements, that is known as the FC fragment. And this FC portion can be identified by the FC receptor which is present on the macrophages, Now this macrophages can identify these antibodies which are already bound to the IgG antibodies, and it can cause extravascular hemolysis. Okay, so macrophages can identify these RBCs. They can cause phagocytosis and leading to extravascular hemolysis. So it can cause extravascular hemolysis. Okay, and sometimes, sorry. Okay, sometimes there can be partial phagocytosis. If there is complete phagocytosis, we are going to get all the classical features of extravascular hemolysis. But if there is partial phagocytosis, they will cause some amount of membrane damage, similar to what we have discussed for hereditary spherocytosis. In hereditary spherocytosis, we discussed that because of progressive membrane damage, progressive membrane loss, there will be formation of the spherocytes. Similarly, in this case also, if there is partial phagocytosis, they can cause gradual slight amount of membrane loss, which can ultimately cause spherocyte formation. It can cause spherocyte formation. Okay. So I repeat it again. So IgG antibodies, they will identify the antigens over the surface of RBCs. Now this IgG antibodies will bind to the RBCs. This IgG antibody is the FC fragment, and this FC portion can be recognized by the macrophages, especially inside the spleen. So these splenic macrophages, once they recognize this FC fragment of the IgG antibody, it can engulf the RBCs and it can cause phagocytosis. If the phagocytosis is complete, it can cause extravascular hemolysis. All the full-blown features of extravascular hemolysis you are going to get. But if the phagocytosis is not complete, it can cause slight membrane damage of the RBCs. Okay, so there will be small membrane damages, and if this membrane damage will persist, there will be gradual loss of membrane that will cause ultimately formation of the spherocytes. This concept we have also discussed when we discussed about the hereditary spherocytosis. And also I have told you at that time that if you're finding spherocytes in a peripheral smear, the most common cause is autoimmune hemolytic anemia. Okay, so most common cause of spherocytes in the peripheral smear is the autoimmune hemolytic anemia. So if in the question they are asking if they are giving a smear of spherocytes and what is the next step, then the answer has to be direct Coombs test, because by doing the Coombs test, we can actually identify these IgG antibodies which are bound to the surface of the RBCs. Okay, so this is the pathogenesis. Now remember, most of these cases are actually idiopathic. That means they are primary. Around 50% of these cases are primary, but some of the cases are secondary also. I mean, you will have some other disease condition, and that is causing secondary, and that will cause this formation of anti-RBC IgG antibodies. For example, connective tissue disorders, classically SLE. Then there are certain drugs. We will discuss this in the next slide. Certain drugs can also cause this type of hemolytic anemia, and also some lymphoid neoplasms. Classically, in the question, they will give the history of CLL, chronic lymphocytic leukemia. Okay, I mean, any lymphoid neoplasm can cause this, but classically in the question, they will give a history of chronic lymphocytic leukemia, and among the connective tissue disorder or autoimmune disorders, they will give history about the SLE. So these are the secondary conditions which can cause secondary autoimmune hemolytic anemia, warm antibody type autoimmune hemolytic anemia. And remember, among all the immune hemolytic anemia, this is the most common type. I mean, the warm antibody type hemolytic anemia is the most common type of immune hemolytic anemia. It constitutes around 80% of the cases. Okay, and you will have predominant extravascular hemolysis. Here the antibodies are usually IgG antibodies, rarely IgG antibodies, and they will bind to RBCs at 37 degrees centigrade. Okay, so these are all the important points. Now that we understood the pathogenesis, now we'll see certain drugs which can cause this type of hemolytic anemia. Okay. So actually, among the drugs, there are three important mechanisms. One is the antigenic drugs, second one is tolerance breaking drugs, and third one is drug dependent immune complex mediated damage. Okay, and antigenic drugs, tolerance breaking drugs, and drug dependent immune complex mediated damage. Okay, so start with the antigenic drugs. Now there are certain drugs like penicillins and cephalosporins. If you give them as a large IV dose, okay, so in large IV doses of penicillin and cephalosporin, they can actually create some of the newer antigenic determinants over the surface of the RBCs. So you can see this is the RBC, and these are some of the newer antigenic determinants. Okay, so they can create newer antigenic determinants over the surface of the RBCs. Now these antigenic determinants will be perceived foreign by our immune system, and now our immune system will produce antibody against this newer antigenic determinants. Okay, and those antibodies can bind to this RBC and they can cause subsequent hemolysis. Okay, they can cause subsequent hemolysis. Now, this antibody after binding of these antibodies, they can actually cause activation of the complements. They can cause activation of the complements. And if there is complete, I mean, full complement activation, it can cause formation of membrane attack complex, which can cause intravascular hemolysis. Okay, this we have already discussed. Whenever the membrane attack complex bind to the cell surface, it can create pores and it can cause influx of the potassium and water and ultimately can cause cell lysis. So in this process, it can cause intravascular hemolysis. But most of the times, they will produce this C3B, which is a component of this complement pathway. And this C3B can bind to the RBC surface. And as we all know, this is a very good opsonizer. I mean, it's a very good opsonin. And this binding of C3B to the RBC surface can cause opsonization of these RBCs, leading to phagocytosis, and that will cause ultimately extravascular hemolysis. And this is the predominant mechanism that is playing role in this particular condition. Okay, so both intravascular and extravascular hemolysis can be seen, but extravascular hemolysis is seen predominantly. Usually, this is seen after 1 to 2 weeks of giving the drug. Okay, so you give high dose of penicillin or cephalosporin, they will create a newer antigenic determinant. Against this antigenic determinant, our body's own immune system will produce some certain antibodies. After this antibody is bound to the RBC surface, it can activate the complements. That can cause activation of, production of membrane attack complex that can cause intravascular hemolysis. And also in the process, they will produce some C3Bs, which can act as opsonins that will cause phagocytosis of the RBCs, leading to extravascular hemolysis. And this extravascular hemolysis is the predominant type of mechanism by which the RBCs are destroyed in this condition. And usually all these things happen after 1 to 2 weeks of giving the drug. Okay. And the prototype examples, as I have told you, these are penicillins and cephalosporins. So these are the important points. Predominantly, they will cause extravascular hemolysis, and usually after 1 to 2 weeks, because it will take some time to produce the antibodies against these antigenic determinants. That's why it will take some time. Okay, so this is the first mechanism. Now we'll see the second mechanism. So what is the second mechanism? Second mechanism is tolerance breaking drug. So before understanding this, you should know what do you mean by tolerance? What do you mean by immune tolerance? Actually, immune tolerance is a mechanism by which our own immune system doesn't react with our own cells. Okay, that means our immune system will identify our own cells and they will identify them as their friends. Okay, and they will not attack them. Okay, so that is known as tolerance. So tolerance is a mechanism by which our immune system doesn't act against our own cells. Okay, but what happens? Sometimes by giving alpha methyl dopa. So again, this is the prototype drug example that you have to remember in this setting. So alpha methyl dopa is a tolerance breaking drug. So alpha methyl dopa is actually antihypertensive. This is also a tolerance breaking drug. That means this will cause some abnormality in the process of tolerance, so that now our body's immune system will recognize normal RBC antigens as foreign. For example, in this case, the RH antigen, as you all know, RH antigen is present on the RBC surface. So what happens if you give the patient alpha methyl dopa? There will be breakage of tolerance, and now our immune system, for example, this is a plasma cell, which will produce the antibodies. Now our immune system will recognize these RH antigens as foreign. And because they are identifying them as foreign, they will produce antibodies against these RH antigens. They will produce antibodies against these RH antigens, and that antibodies will go and bind to the RBCs, and subsequently it will cause hemolysis. Okay, once RBCs are bound to RBCs, they will cause hemolysis. But usually this alpha methyl dopa related hemolysis is only found in 1% of the cases. It is only found in 1% of the cases, and this is the mechanism. Okay, so that is the concept of tolerance breaking drugs. Now coming to the third mechanism, drug dependent immune complex mediated damage. So what happens in this condition? Here the prototype example is quinidine. So what happens? Once you give quinidine to a patient, usually this is given for malaria. So once you give quinidine, this quinidine can go and bind to the surface of the RBC. It can go and bind to the surface of the RBCs. There will be some antibodies that will be produced against this quinidine. Of course, quinidine is a foreign substance, so our body's immune system will try to produce some antibodies against this quinidine. Now, those antibodies will go and bind to the quinidines. and they will make a immune complex. They will make a immune complex. And all this immune complex formation is happening over the surface of the RBC because quinidine is bound to the RBCs. Okay, so it is clear. So antibodies will be formed against quinidine, and quinidine and antibodies, they will make the immune complex. This immune complex is happening over the surface of the RBCs. And this immune complex can also activate the complements. They can also activate the complements, and the same process will continue, and there will be subsequent hemolysis. Okay, so quinidines, they will classically cause immune complex mediated hemolysis. Okay, so these are the three very important drug-induced mechanisms for hemolytic anemia. Okay, so I'll just revise it again. So antigenic drugs include penicillin and cephalosporins, which can create newer antigenic determinants over the surface of the RBCs against which will produce the antibodies, and they will cause subsequent hemolysis. Alpha methyl dopa classically causes breakage in the tolerance, leading to antibody formation against the RBC surface antigens, which are normally expressed, and these antibodies can cause hemolysis, but usually it is rare. Only 1% of the cases you will get this condition. And the last one is your quinidine mediated immune complex mediated hemolysis, hemolytic anemia. Okay, so that is about the drug induced hemolytic anemia. So in all these conditions also you can identify the antibodies over the surface of the RBC. So in all these conditions, DCT is useful, direct interest is useful. Okay, so this is about the warm type. Now we'll go to the cold type hemolytic anemia. So cold type means here the antibodies will bind to the RBCs at a temperature of 0 to 4 degrees centigrade. 0 to 4 degrees centigrade. That means in this condition, in these antibodies, these pathogenic antibodies, they will not bind to the RBCs at core body temperature. Core body temperature is 37 degrees centigrade. And at 37 degrees centigrade, they will not bind to the RBCs. They will bind to RBCs only in temperature range of 0 to 4 degrees centigrade. Usually these are IgM antibodies. IgM. I told you for warm type antibodies are IgG and IgA, and cold type antibodies are IgM antibodies. So what happens now? Let us understand the pathogenesis. Usually they will bind to the RBCs in the acral area. Acral area means the hands and the feet. Hands and the feet. Sometimes our acral area they are exposed to extreme cold temperatures, and at that temperature, these IgM antibodies, they will bind to this surface of the RBCs. Now, once they're bound to these RBCs, they can cause two things. The first thing is they can cause agglutination of the RBCs. As you can see here, they can cause agglutination of the RBCs in this area. And because of this agglutination in the microvasculature in the acral areas, they can actually cause this they can cause pallor in the peripheral areas. So they can cause pallor. Once the blood supply is cut off from these areas, there will be excessive accumulation of deoxygenated hemoglobins. And deoxyhemoglobins can cause cyanosis. It can cause cyanosis. And as this process continues, there will be reactive hyperemia. I mean, the body will understand that there is reduced supply of blood into these areas, and the body will try to deliver more and more blood to these areas. That is known as the process of hyperemia. Okay, so body will try to provide more and more blood to these areas. So ultimately, once the clots are released, there will be increased blood flow that will cause redness or hyperemia or redness. And this classical triad, this classical sequential triad, it is known as the Raynaud phenomenon. Raynaud phenomenon. We'll discuss more on this when we'll discuss about the vascular pathology also, but this is the concept. PCR, pallor, followed by cyanosis, followed by redness. And I hope you understood the concept. Pallor is because of the occlusion of the microvasculature. Cyanosis is because of the increase in deoxygenated hemoglobins. And redness is because of the reactive hyperemia. Okay, and this classical triad is seen in this condition. Okay, cold agglutinin disease. There are certain other conditions also where we are going to get Raynaud phenomenon that we will discuss later. Okay, so in a patient, in a question, if they're asking a question on hemolytic anemia and they are giving this history, that means they are asking you about the cold agglutinin type hemolytic anemia. Okay, so this is the first thing that they are going to do. They'll cause this agglutination, and also if you look at the peripheral smear, you can definitely identify these RBC agglutinations. As you can see, so here the RBCs are agglutinated. Okay, so these are all RBC agglutinations. If you are doing peripheral smear in this patient. Okay, so this is the first thing that they are going to do. They will cause RBC agglutination. Next thing is this IgMs. As I have told you previously, IgMs are actually, they have highest propensity to cause complement activation. Okay, so they will also cause complement activation. As you can see here, C means complement activation. They can cause severe complement activation. Now what happens? Now when this blood will go to, when the blood from this area, from the acral area, will come to the core body. At core body temperature of 37 degrees centigrade, this IgM antibodies will be released from the surface of the RBCs. Okay, these IgM antibodies will be released from the surface of the RBCs because they cannot bind to the RBCs at 37 degrees centigrade. So what happens? Even though IgM is released, the complement proteins are still present near the RBCs. The complement proteins are still present near the RBCs. However, the entire process of, the entire complement pathway cannot be completed because the IgM is already released from the surface of the RBCs. So the entire complement pathway cannot be completed. However, some complement proteins have already produced, and the most important among them is C3b. And that C3b can bind to RBCs directly, and it can cause phagocytosis leading to extravascular hemolysis. So this is a very important concept to understand because many times we think that in cold agglutinin disease, the IgM antibodies are binding to the RBCs and they are activating complements. So, so intravascular hemolysis, the membrane attack complex mediated hemolysis or the intravascular hemolysis should be the predominant mechanism in this condition, but that is not the case. This is because the IgM antibodies are dissociated at core body temperature, and only the C3b is left, which will cause extravascular hemolysis. It will cause extravascular hemolysis. So both in warm type hemolytic anemia and cold type hemolytic anemia, we are going to get extravascular hemolysis. And one more point is, if you do direct Coombs test in this condition, you are going to get C3b over the RBC surface. You are going to find C3b over the RBC surface. You will not get the IgM antibodies because those are not bound to the RBCs at core body temperature. Okay, so it is clear. So that is why I have shown you the first image when I discussed about the direct Coombs test. You can identify the antibodies and you can identify the C3b. And from this understanding, now we know that in patients with warm autoimmune hemolytic anemia, you will find IgG, and in cold, you are going to get C3b. So C3b, if you are getting C3b, this is a surrogate marker that this person is having cold type autoimmune hemolytic anemia. Okay, so you are doing direct Coombs test. If you are getting IgG antibodies against the RBCs, that means it is warm autoimmune hemolytic anemia. And if you are getting C3b, that is cold autoimmune hemolytic anemia. Okay, so this concept is clear. Now, this cold agglutinin type, this can be acute or it can be chronic. Acute is usually seen in some of the viral infections. Okay, and rarely with bacterial infections also. So, if I just write those infections, important ones are mycoplasma pneumonia infection. This will make anti-capital I IgM antibodies. Capital I, this is an antigen over the surface of the RBCs. Okay, over the surface of RBCs, we have various antigens, and one of them is this I antibody. I antibody can be capital I, can be small I. The infectious mononucleosis, which is caused by Epstein-Barr virus, this can produce anti-small I IgM antibodies. So these two are important. Mycoplasma will cause anti-capital I antibodies. Infectious mononucleosis can cause anti-small I antibodies. So both of them can cause cold agglutinin type hemolytic anemia. Also, there are certain other infections like CMV, influenza, and HIV. All of them can also cause this type of hemolytic anemia. Chronic cases are usually either it can be primary or idiopathic, or it can be due to some lymphoproliferative disorder. Lymphoproliferative disorder. Lymphoproliferative disorder, they can cause both warm type autoimmune hemolytic anemia. They can also cause cold agglutinin type hemolytic anemia. And I told you when I discussed about warm hemolytic anemia, I told you the important one to remember is CLL, that is chronic lymphocytic leukemia. But here the important one is LPL, that is lymphoplasmacytic lymphoma. Otherwise, you can remember as Waldenström macroglobulinemia. Okay, so don't worry about that because we are going to discuss all those things in detail when we will discuss about the lymphomas. Okay, so for cold agglutinin, just remember about lymphoplasmacytic lymphoma, and for warm, you remember CLL. Okay, and among the acute, these are important: mycoplasma, which cause anti-capital I antibody, and Epstein-Barr virus, which cause infectious mononucleosis that will produce anti-small I antibodies. Okay, and these are IgM antibodies. They will bind to the surface of the RBCs at 0 to 4 degrees centigrade. They will be dissociated at 37 degrees centigrade. However, the complement protein C3b will remain. That will cause extravascular hemolysis. And if you do direct Coombs test, you are going to get C3b over the surface of the RBCs. And these patients will classically present with this Raynaud phenomenon. And if you do peripheral smear, you are going to get this agglutinins in the peripheral smear. Okay. Now we'll go to one of the very interesting type of hemolytic anemia, that is cold hemolysin type hemolytic anemia. That means here also antibodies will bind to the RBC surface at cold temperature, that is 0 to 4 degrees centigrade. But here there will be no agglutination. There will be hemolysis. Okay, one more point. Why this agglutination is happening here? Okay, so why this agglutination is happening? Because this IgM, these are pentameric structures. Okay, so IgMs are actually these IgM antibodies, they are actually pentameric structures. I mean, 5 monomers will be joined to each other through a linkage. So they are actually pentameric. That means they are containing 5 antibodies. So that is why when this IgM antibody will bind to RBCs, when it will bind to RBCs, it can actually cause agglutination. So that's why IgM antibodies, they have the propensity to cause RBC agglutination. But IgG antibody, which is a monomeric structure, it will not cause agglutination. Okay, it will not cause agglutination. So in cold hemolysin type, the antibodies will bind to the RBCs at cold temperature, but they will not cause agglutination, they will cause hemolysis. Okay, and this is caused by IgG antibody. It is caused by IgG antibodies. But I have told you previously that IgG antibodies bind to the RBC antigens at 37 degrees centigrade. But this is exception. This is a very exceptional case where certain IgG antibodies can bind to the RBC surface at cold temperature. But again, these antibodies are also, if you see here, they are also bound to RBC surface at core body temperature. That means they will bind at low temperature, 0 to 4 degrees centigrade, and also they are bound to this RBC at 37 degrees centigrade. Unlike the IgM antibodies, IgM antibodies will be released from the RBCs at core body temperature, but these IgG antibodies will still be attached to the RBCs at 37 degrees centigrade. That's why these are known as bithermal antibodies. These IgG antibodies are known as bithermal antibodies. Okay. Otherwise, these are known as the donut Land-Steiner antibodies. Donor Land-Steiner antibodies. Okay. And these antibodies, these IgG antibodies, are directed against a certain type of antigen that is known as the P antigen. P antigen. I hope you remember other function of P antigen. So P antigens over the surface of the RBCs, they also act as receptor for Parvo B19 virus. Okay, so we have discussed about the aplastic crisis that happens in any kind of hemolytic anemia. We have discussed it under hereditary spherocytosis. We have also discussed under sickle cell disease that in those patients, Parvo B19 can cause transient halt in the process of erythropoiesis, that is known as the aplastic crisis, and those parvo B19 virus can attack the RBCs or the precursor erythroblast by binding to this P antigen. And this P antigen is also responsible for this cold hemolysin type hemolytic anemia, because here the IgG antibodies are directed against this antigen, this P antigen. Okay, so it is clear. So what is happening? Let's see what is happening. So at 0 to 4 degrees centigrade, that means when the patient is exposed to cold, these IgG antibodies will bind to the surface of the RBCs. Now, when this, and they will not produce any agglutination, when this blood will go to the core body at 37 degrees centigrade, they can actually activate the complements. They will activate the complements. Here, the antibody is already bound to the surface of the RBC, so it can actually complete the entire complement pathway. It can complete the entire complement pathway so that membrane attack complex will be activated. And this membrane attack complex can cause lysis of the RBCs, and that will cause intravascular hemolysis. And this is responsible for red urine. We have discussed in PNH. In PNH also, there will be red urine because of intravascular hemolysis. And in PNH, it was happening during the night time. At least the initial belief was it was during the night time because during the night time there is complement activation, and that is causing hemolysis. And usually those patients will present as early morning hemoglobinuria. I mean red urine in the early morning phase. Here the patients will have red urine after a period of exposure to the cold. And the classical history that they will give is after coming out of the swimming pool. After coming out of the swimming pool, when the patient will micturate, they'll have red urine. Because inside the swimming pool, sometimes they will expose to extreme cold temperature, and that will activate these IgG antibodies, which will bind to the RBCs. And when they come out of the swimming pool, when the temperature will increase to normal core body temperature, they can activate the complements, and this complement pathway will be a complete activation because IgG antibodies are still bound to the RBCs. That will cause formation of membrane attack complex. That will cause lysis of the RBCs, predominant intravascular hemolysis, that will cause hemoglobinuria or red urine. So if in the exam they want to ask about the cold hemolytic type hemolytic anemia, they will give this history of red urine after coming out of the swimming pool. Okay, and this is classically described as paroxysmal cold hemoglobinuria. So now you understood about the paroxysmal nocturnal hemoglobinuria, and you also understood about the paroxysmal cold hemoglobinuria. Why it is called as paroxysmal cold hemoglobinuria. Usually this condition is seen in children following certain viral infections. And usually these are self-limiting, recover within 1 month. And also it is described with respect to syphilis. It is also associated with syphilis. These are all the concepts about paroxysmal cold hemoglobinuria. I'll just highlight the important points again. So this is known as paroxysmal cold hemoglobinuria, usually found in children after viral infection. These are self-limited, recover within 1 month. Also associated with syphilis. These are caused by IgG antibodies, which have a bi-thermal property. That means it can bind to RBCs. Initially they'll bind at core body, the lower temperature of 0 to 4 degrees centigrade, and they'll persist to bind at 37 degrees centigrade. These are otherwise known as the donor-Landsteiner antibodies, and there will be predominant intravascular hemolysis. Because these are all the important points about the paroxysmal cold hemoglobinuria. Okay, so I'll just tell about the treatment of warm antibody hemolytic anemia. So this is basically because of immune system activation. So these patients are usually treated with immunosuppressants. We start with steroids. Most of the patients will respond to steroids. If they are not responding to steroid, we'll go to the second line immunosuppressive therapies. Okay, and if it is secondary, if it is secondary to some other conditions, we have to treat that primary condition. That means if it is secondary to SLA, you have to treat SLA. If it is secondary to drugs, you have to withhold the drug. If it is due to lymphoid neoplasia like CLL, then this is important point. If autoimmune hemolytic anemia is happening in a patient with CLL, those patients also will just treat for autoimmune hemolytic anemia. We'll just treat those patients with steroids. Mere presence of autoimmune hemolytic anemia in patient with CLL doesn't qualify for the treatment of CLL itself. Okay, we'll discuss more on that when we'll discuss about the CLL. We'll discuss that CLL is actually a condition which is, It's a very benign type of leukemia. CLL is chronic lymphocytic leukemia. It's a very benign kind of leukemia. I mean, most of the patient doesn't need any treatment. You can just observe them and follow up them. Okay. And of course, there are certain indications in which we have to treat these conditions, but most of these patients doesn't need any treatment. Okay. And if these patients develop this autoimmune hemolytic anemia, we can just treat them with steroids. We need not treat the CLL per se with chemotherapy. Okay, so that is one concept you remember. We'll discuss more on that when we discuss about the CLL. So basically, warm autoimmune hemolytic anemia, we treat with steroids. If not responding, or if dependent on steroids, we can go for other second line immune suppressive therapies, but most of the patients will respond to steroids. And if they have this, I mean, if they're associated with secondary conditions, we have to manage the secondary conditions except CLL. Cold agglutinin type hemolytic anemia, this usually doesn't respond to steroids. Okay, they are usually resistant to steroids. We have to treat them with other immunosuppressive therapies, especially rituximab. Okay, usually rituximab is used for this condition. This condition most of the times doesn't need any treatment because these are self-limiting. Okay, so as you have understood all the immune hemolytic anemias, now let us finish this chapter of hemolytic anemia with the last part, that is hemolytic anemia resulting from trauma to the red cells. Okay, there are certain other conditions like certain infections, especially the malaria, which can cause hemolytic anemia. Those infection-related hemolytic anemia we'll discuss in when we'll discuss about the individual infections. Okay, so that I'm not going to discuss now. I'll just discuss with the hemolytic anemia resulting from trauma to the red cells. So sometimes, I mean, this can happen either because of it can be microangiopathic hemolytic anemia, or it can be macroangiopathic hemolytic anemia. So what do you mean by microangiopathic hemolytic anemia? Here, there will be certain microthrombi formation in the microvasculature. I mean the small blood vessels. So in the small blood vessels, there can be, in certain situations, there will be microthrombi formation, and this microthrombi formation can damage to the RBCs. When RBCs try to go through this microvasculature, it can cause damage to the RBCs. So that is the mechanism behind microangiopathic hemolytic anemias. And this microthrombi, it can be platelet-rich thrombi. This usually found in you can find in hemolytic uremic syndrome or thrombotic thrombocytopenic purpura, or it can be fibrin-rich thrombi, which you will get in DIC. DIC is disseminated intravascular coagulation or HELP syndrome. Don't worry about all these things. These things we'll discuss in detail when we will discuss about the platelet disorders. Okay, so don't worry about that. Just for the timing, you remember there will be some microthrombi formation in the microvasculature, which can cause RBC test, which can cause trauma to the RBCs. And because of this trauma, they can produce a very peculiar type of RBCs, like this, as you can see here. These are actually known as cystocytes. Cystocytes, or sometimes known as the fragmented RBCs. Okay, so these are cystocytes. So cystocytes in the peripheral blood, it suggests that there is some microangiopathic hemolytic anemia going on. Okay, so all the rest of the things we will discuss later. And there is another condition that is known as the macroangiopathic hemolytic anemia. This is usually associated with severe aortic valve stenosis, or if the patient has prosthetic valve. If the patient has a prosthetic valve. Okay, so because of this severe aortic valve stenosis, when the RBCs, when the blood is trying to go through this stenotic valve, it can actually damage to the RBCs. Okay, so those are grouped under the macroangiopathic hemolytic anemia. So with that, we are ending the section of hemolytic anemias.